Hi, everybody. I'm Joanne Sheehan. Welcome to CCO Club webinar number 007. I have 5 questions that have been presented to us by members of our club that I will be going over today, and hopefully you'll learn something new. The very first question has to do with CPT codes 10022 and 76942. And the question is, how, when, and why. So how do we use these? When do we use it, and why? And it can be a little confusing. So the question is, how, when, and why is it appropriate to bill a 76942 when also billing a 10022? Doesn't 10022 include imaging? Seems like double dipping. There are no correct coding initiative edits with the pair, but I just wanted to know the logic behind billing both sides. Thank you. So let's first look at CPT code 10022. And I will admit that this description is a little confusing. The 10022 means fine needle aspiration. And after the semicolon, it says with imaging guidance. Now, if you look in your CPT manual at 10021, it says fine needle aspiration without imaging guidance. But in this case, it does have imaging guidance with it. However, the imaging guidance for this code is not part of the 10022. Now, when I pull this up on the CPT manual on Find a Code and Supercoder, as well as in the manual, it has all this information. I mean, this is a lot like on the slide, but this is what, if you're a member of the club and you're already a coder, you may already know this, but if you're a student and learning, it's very important to pay attention to the guidelines. So in this case, the first thing it says is AMA guidelines for placement of percutaneous, which means through the skin, localization devices such as clips, metallic pellets, or during a breast biopsy. And if it is during a breast biopsy, it says C19081 through 19086. But that really is not applicable to this question, but it's in the guidelines, so you have to scan it. But underneath that guideline comes the important guideline, where it says, for radiological supervision and interpretation, see the CPT codes, and it gives you a few: 76942, which is the one we're focusing on, 77002, 77012, and 77021. So that you would zero in on because imaging guidance is radiological, okay? And then beneath there are additional guidelines so that if you were coding some type of a percutaneous or fine needle, if you were coding like a percutaneous needle biopsy other than a fine needle aspiration, the CPT book tells you right there in black and white, this is where you have to go to pick the proper code. Don't use 10021 or 10022, okay? And it gives you the whole list. So for the breast, it's 19081 through 19086, and it goes all the way down to the paravertebral tissue, 62269. So because the question is focused on the 10022 fine needle aspiration with imaging guidance and the 76942, that's what we will focus on. But if you were looking up different things because you weren't sure of the code, then these guidelines would tell you where to go, point you in the right direction. So make sure you pay attention always to the guidelines. Now, a fine needle aspiration is a type of biopsy procedure. It's a very thin needle, and it's inserted into an area of abnormal appearing tissue or body fluid, like a lump. And as with other types of biopsies, the sample collected during the fine needle aspiration can help make a diagnosis or rule out conditions and problems such as cancer. And so what is fine needle aspiration? It looks just like this, where the doctor would just insert a needle and draw the fluid. It's aspiration, drawing the fluid out of the skin. But this is a fine needle aspiration with ultrasonic, guidance. So you'll see a picture of that in a second. But what is a percutaneous needle biopsy? While excisional biopsy is still appropriate in certain cases, which includes diagnosis of breast and brain tumors, percutaneous beneath the skin needle biopsy has become the standard of care in the diagnosis of most tumors throughout the body. And that needle biopsy also is used to diagnose non-cancerous conditions such as infection. Okay, so that's important to know as well. So here's a couple of examples of a percutaneous needle biopsy. And here you see the needle going into the vocal cord where they would be drawing fluid out of here and have it sampled to see if it was cancerous. And then here is a liver biopsy, and it's a small slender core of tissue that's removed with a biopsy needle. So it just gives you a visual, and I'm one that loves visuals, so you'll get a lot of those. Fine needle cytologic and fluid aspiration biopsies are reported using 10021, as I mentioned before, which is the fine needle aspiration without imaging guidance. And the 10022 is with imaging guidance. It is also appropriate to report the imaging guidance used while performing fluid aspirations. So if it says with imaging guidance, look below that for the guidelines. And if it's offering you imaging guidance CPT codes and where to go, you have to do that. Sometimes the codes will include the imaging, but in this case, it doesn't. And you only would know that if you read the guidelines beneath that code. So aspirated samples from these procedures are sent to pathology for cytologic examination. And these are differentiated from core biopsy samples, which are sent to pathology for histologic evaluation. And this is a picture of a core biopsy, which is done all the time on men and women's breasts for evaluation. And that is an example here of the needle going in and doing a core biopsy, which is going to be sent to the lab. Cytology is the medical and scientific study of cells. So the cytology refers to a branch of pathology, the medical specialty that deals with making diagnoses of diseases and conditions throughout the examination, looking at tissue samples from the body. And I don't claim to know everything there is about cells or the study of cells, but this is an example of a cell membrane, and you can just see here the cell, the nucleus, and the nucleolus right here, and it just keeps going on, but this is what cytology is. Now, histology is the study of the form of structures seen under the microscope, and it can be light, electron, or infrared, and it's also called microscopic anatomy, as opposed to gross anatomy, which involves structures that you can just look at through the human eye, naked eye, no help at all. And here's a picture of a pathologist looking through a microscope at tissues. And there are 4 tissues: the connective, epithelial, muscle, and nervous tissue. Now here is the imaging modality. The imaging modality that is used should be reported separately. And here are some other CPT codes that you would use for imaging. And in this case, the 76942 that is in question is listed. It should be noted that multiple sample passes at the same site or different sites of the same lesion should result in one biopsy code being reported. It is very common when you do a fine needle aspiration that where you see the arrow pointing to the imaging right here, the ultrasonic guidance, and there's the needle right here, but that provider will probably insert the needle in more than one location in that area, but you only bill it once. So if he tells you went in 5 times, that's okay. He's drawing the samples from different parts of that area, but you only use the 10022 once. So you always bill 76942 with 10022 when the documentation tells you that the fine needle aspiration was ultrasound guided. And so in this particular case, the club member used the 76942, and that's fine. That's the code we would focus on. But depending on the documentation, you may actually use a different code in the 70,000 range, which is the radiology section of your CPT, but you would only have the options that are presented to you in your CPT manual. So that, and here again is another example of the ultrasound and the needle going in, going through the tube and being collected into this container here. And I know I keep repeating myself, but honestly, there's certain times where I do say things different ways just because it's a question that's always confusing to students, and that's why I'm doing this. But here is another example of the fine needle without the imaging guidance. 10022 just tells you that imaging was used, but does not specify what type of imaging was used, like ultrasound, fluoroscopic. That would be in the documentation. So based on the documentation, you would use the proper imaging CPT code. Okay, but this is one without the imaging, and you can see there's no paraphernalia here next to that needle. So the added imaging code 76942 tells what type of imaging was used for this particular fine needle aspiration, and the CPT book does explain that the 10022 for radiological supervision and interpretation, and those are the codes that they're giving you. So the guidelines explain it all. So if you have not sat for your CPC exam or even your CPB, because there are 15 questions on your billing exam, just remember guidelines, guidelines, guidelines. I cannot stress that enough. Okay? So now when skin is prepped to do an ultrasound guidance with the fine needle aspiration, the skin is typically prepped with something called DuraPrep. And under ultrasound guidance, the nodule on the left and a nodule on the right, as an example, were biopsied and sent to pathology. The left nodule contains a large amount of colloid as well, which was aspirated. Patient tolerated procedure well. She left the office without any complications and was stable. So this is an example of a coding documentation, and everything is written right there. Now, DuraPrep solution, it allows the continual release of a free iodine, and it kills the bacteria while that film is on the skin, because as you know that when you have ultrasound, typically they put like a kind of a gel or film over it so that the ultrasound can move smoothly over the skin or whatever. And so the DuraPrep solution is there, keeping the bacteria, killing the bacteria while the film is on the screen. And the colloid nodules, there are different names for colloid nodules. They're known as adenomatous nodules. So your doctor may use that instead of colloid, or colloid nodular goiter. Goiter is a very common term. And these are benign, non-cancerous enlargement of thyroid tissue. And that's what we're talking about in this particular coding example. They can grow large and they can have more than one, but they're not malignant and they don't spread beyond the thyroid gland. So here's an example here. You can see in the ultrasound, this is the fine needle aspiration going right into this nodule, which is the dark section here, black. That's the thyroid nodule. I think it's very hard to read these ultrasound, images. I'm always amazed, even when you look at a mom and they see their baby for the first time, and the ultrasonographer can say, "Oh, it's a boy, it's a girl," and I'm still seeing a blob. I don't understand it. But in this case, I think it's pretty clear. You can really see the shadowing of the thyroid nodule. So because the skin was prepped with DuraPrep, it was under ultrasonic guidance, the nodule was there, and they aspirated the colloid. So your coding answer would be, in this case, the 10022 and the 76942, and they would be billed together. So just remember that the 76942 is ultrasonic guidance for needle placement, and that needle placement could mean a biopsy or aspiration, and it is imaging with the supervision and interpretation included. Okay. Some of the places where a fine needle aspiration can take place when sampling cells, it could be a thyroid, a non-thyroid, neck, example, parotid, cervical lymph nodes, the breast, liver, lymph nodes, lung, bone, gastrointestinal tract, and mediastinum, to name a few. So it's not just like one place where it could be. And honestly, if you were having a fine needle aspiration done, let's say on the top of your hand, because there was just a little lump there, you may not need the ultrasound guidance because it's small fluid and they just want to take a sampling to see if it's an infection or what it is. Whereas when you get into larger parts of the body or lymph nodes, then you probably would do that. And the fine needle aspiration technique will vary depending on the system being targeted and the nature of the lesion. So the technique's common to all procedures. And here is an example There are different ones like lidocaine. In this particular case, a local anesthesia with 2% buffered lidocaine. Then what happens is they advance the fine needle under imaging guidance until the tip is in the intended area for the biopsy. And then when they're done, they remove the stylet. And this is the stylet, or the little needle. And the fine needle technique will vary depending on the system being targeted and the nature of the lesion. And techniques common to all procedures include multiple short passes through the lesion, which I mentioned, and you only bill it once, filling the needle with cells, removal of the needle with appropriate disposition of the cells, for example, a slide for a smear or a container for a cell block. And here you have to the left what the slide would look like, and then this is what the container for a cell block would be. Okay, and it would be labeled. And multiple samples are usually obtained in a session. So don't be tricked if your doctor writes that he did 5 samplings. You can only bill it once. So the tips regarding the 76942 and also 76937, but we're not going to focus on that. The 76942 is an ultrasound imaging guidance and is used only for biopsy, injection, and aspiration, but it's to be coded only with non-vascular procedures. Where the 76937 is vascular, we're focusing on the 76942, and that is non-vascular. So remember that as well. So any questions for that? I don't see any questions for that. So the next subject that we will be talking about is quadriplegia. C4 through C7, which is the cervical part of the spine, based on a traumatic fracture case. Now, sometimes when I get a question, interpreting it the way I read it, and sometimes it may not be what the student is asking or the club member. So I hope that I interpreted this question correctly, but let's move forward and see. I'm trying to code incomplete quadriplegia with traumatic fracture of C4 through C7. Would I use G82.52 quadriplegia C1 through C4 incomplete, in addition to G82.54 quadriplegia C5 through C7 incomplete? Also, I had to go back years, 2015, into the patient's record to find the location of the fracture and whether it was complete or incomplete. But I did find documentation thanks to one spiffy documenting doctor. Is it okay to use old documentation to code to the highest specificity? The providers have been coding the G82.50 quadriplegia unspecified, and we continue to see denials. Well, one of the reasons why you see a lot of denials is that there are very, very specific guidelines in your ICD-10-CM manual that pertain to quadriplegia. Okay, and you have to follow them. And I'm not taking away the fact that every payer has their own set of rules, but the general rule of thumb is that you have to follow these specific guidelines with something like quadriplegia, because there's just more to it. But let's move forward and I'll show you. So an incomplete quadriplegia with traumatic fracture of C4 to C7, and here we see this is the spinal cord, which is all along the nerve endings, all along the vertebrae, and in purple we see the spinal cord. Okay, and they're the 8 cervical pairs, and all the purple is where this particular injury takes place. So what is an acute spinal cord injury? Spinal cord is the bundle of nerves that carries messages between the brain and the rest of the body. And an acute spinal cord injury is due to traumatic injury that can either result in a bruise, such as called a contusion, a partial tear, or a complete tear called a transection in the spinal cord. And the spinal cord injury is more common in men and young adults. Spinal cord injuries result in a decreased or absence of movement, sensation, and body organ function below the level of the injury. And the most common sites of injury are the cervical, which is the neck, and the thoracic areas, which is like the chest. The spinal cord injury is a common cause of permanent disability and death in children and adults. So when you look here at this diagram, where it's quadriplegia, it's the loss of movement and sensation in all 4 limbs, and this is the area of quadriplegia. And paraplegia is the loss of movement and sensation in the lower half of the body. But here we have the cervical section, and then you'll see like T1 to T2, and that is all the area that is affected. So spinal cord injuries can be divided into two types, complete and incomplete. The complete injury means that there is no function below the level of the injury. There's neither sensation or movement, and both sides of the body are equally affected. Complete injuries can happen at any level of the spinal cord. But we're talking about incomplete injury today. And an incomplete injury means that there is some function below the level of the injury, movement in one limb more than the other, feeling in parts of the body, and in other parts there's no feeling, more function on one side than the other. Incomplete injuries can happen at any level of the spinal cord as well. But again, we're focusing on the cervical area, so that's affecting from here down. Generally, the higher up the level of the injury, meaning the cervical area, to the spinal cord, the more severe the symptoms. For example, an injury at C2 or C3, the second and third vertebrae in the spinal column, affects the respiratory muscles and the ability to breathe, where a lower injury in the lumbar vertebrae can affect nerves, muscle control to the bladder, bowel, and legs. And there are three classifications for the type of injury. First, we have quadriplegia, which means quad means four. This involves loss of movement and sensation in all four limbs, meaning arms and legs. It happens as a result of injury at T1, the thoracic 1 level, all the way up into the cervical area. Quadriplegia affects the chest muscles, and injuries at C4, which we are talking about, C4 to C7 or above, require a mechanical breathing machine or a ventilator. A word that is used quite often and means the same thing as quadriplegia is tetraplegia. So if you see your doctor and referring to that, tetraplegia is not triplegia, which is down below, which we'll look at in a sec. Paraplegia means two parts. This involves loss of movement and sensation in the lower half of the body, right and left legs. It usually happens as a result of injuries at T1, which is right below the cervical area and below. And triplegia, tri means three, and this involves the loss of movement and sensation in one arm and both legs, and usually results from incomplete spinal cord injury. So this triplegia means three. Tetra means four. So tetra and quadra mean the same thing. So an incomplete quadriplegia, this involves loss of movement and sensation in all four limbs, and it usually happens as a result, as I said, in injuries T1 and above. And quadriplegia also affects the chest muscles and injuries and requires some type of a ventilator. So here's tetraplegia cervical, the nerves. So it's C1 to C2, 2, 3, 4, 5, and all the way down to 7. It's right here. And this is the area in green that we're talking about, okay? And any injuries from T1 down mean no muscle or sensory control. Now, I just took a portion of this just to show you as an example, the different levels of injury, possible impairment, and rehabilitation potential. So let's look at C4. Quadriplegia and breathing difficulty is the possible impairment. And rehab, dependent for all cares, usually needs a ventilator. Injury C5, quadriplegia with some shoulder and elbow function impairment possible, may be able to feed self using assistive devices, usually can breathe without a ventilator, but may need other types of respiratory support. Unfortunately, this patient has C4, which means he does need a ventilator, and then we go to C5. C6, quadriplegia with shoulder, elbow, and some wrist function, may be able to propel a wheelchair inside on smooth surfaces, may be able to help feed, groom, and dress self, dependent on others for transfers. And then C7, quadriplegia with shoulder, elbow, wrist, and some hand function, may be able to propel the wheelchair outside, transfer self, and drive a car with special adaptations, may be able to help with bowel and bladder programs. But this poor patient has a really bad injury from C4 through C7, and and so he does have problems with his breathing. Now, the doctors use GA 2.50, which is quadriplegia unspecified, and they don't get paid. So when you look in one of your websites, such as findacode.com that CCO uses, there's a note that says this category is to be used only when the listed conditions are reported without further specification or are stated to be old or long-standing but of unspecified cause. The category is also for use in multiple coding to identify these conditions resulting from any cause. We happen to know that the areas, the levels where the cervix was damaged. So this unspecified really is not a good code for the doctors to be choosing to use. When we look at the excludes one, which would appear in your ICD-10 manual, it says that if you use quadriplegia unspecified, then you would not use the congenital cerebral palsy, the functional quadriplegia, or the hysterical paralysis. If the doctor used one of these diagnosis codes, you would not be using the G8250. Remember, they cannot be coded together. It's either this one or the other, one or the other. The excludes two can be added to the G82.50, and there are a number of conditions. I'll read them once, but they will repeat on the next two slides. Certain conditions originating in the perinatal period, certain infectious and parasitic diseases, complications of pregnancy, childbirth, and the puerperium, congenital malformations, deformations, and chromosomal abnormalities, endocrine, nutritional, and metabolic diseases. I highlighted injury, poisoning, and certain other consequences of external causes because we know this patient has quadriplegia due to traumatic fractures in C4 through 7. Neoplasms, and then symptom signs in abnormal clinical and laboratory findings not elsewhere classified. So I always try to gear towards specificity. I don't like unspecified. And in this case, we have enough information to be specific. So to just use G82.50 based on the documentation, I can understand why this claim is not getting paid. So let's look at the G82.52, which our club member presented. And that's quadriplegia, C1 through C4, incomplete. The same note, is there where it says only when listed conditions are reported without further specification, you should just use the specific code. However, if there's multiple coding to identify these conditions resulting from any cause, you would use them. And again, in this case, we have injury, poisoning, certain other consequences of external causes, which is traumatic fracture, which falls into the S series in your ICD-10 manual. The doctor may also use different terms for quadriplegia, C1 through C4 incomplete. He could just write incomplete C1 through C4 quadriplegia, or incomplete quadriplegia due to spinal cord lesion between first and fourth cervical vertebra. Incomplete tetraplegia due to spinal cord lesion at C1 to C4 level, and then quadriplegia C1 through C4 incomplete, which is how it's presented in your ICD-10 manual. But they all mean the same thing. So you have to know, based on what the doctor writes, where to look. Okay, so we know that the injuries start at C4. So G82.52 is absolutely correct, and I would go with that code. Now the G82.54 focuses on C5 through C7 incomplete. And it's the same thing. If that's just the code and there's nothing else that goes with it, then that's what you would use, a very specific code. But again, we are also looking that this patient became quadriplegic due to a traumatic injury, fracture. So I'm focusing again on the excludes two. So you would use this and you would use this because two or more codes can be built together at the same time. Just when we move forward, pay attention to how the documentation guidelines are in your ICD-10 manual. They're wonderful. They take you by the hand and they really tell you the sequence. So right now, our coder has chosen as an option to the G82.50 to use G82.52 and G82.54. And I commend her because those are the right answers. She should be using those. Okay, so when we look at the codes that she had suggested, we have the G8252, and that's the quadriplegia, C1 through C4, incomplete. You'll also see codes in there that say complete for this area, so make sure you pay attention to the incomplete. And then G82.54, quadriplegia, C5 through 7, incomplete. So the injuries are at C4, C5, C6, and C7. And here we have 4, 5, 6, and 7, all right here. Okay. So you use multiple coding to identify these conditions, and it is incomplete, resulting from any cause. And that was in the notes. And cause is the traumatic fracture of C4 through C7. So when you look up these codes in Find a Code, you see that the main code, the GA2, means paraplegia and tetraplegia. And the cause of this is, and in this case, it has S12.0, fracture of first cervical vertebra. But we know it was not, so I wouldn't look at that code. But then it says 612.2. It could have been a fracture of other specified cervical vertebra. C13.0, traumatic rupture of cervical intervertebral disc. We know it's not this dislocation. We know it's not a sprain and strain, and we know it's not a concussion and edema of the cervical spinal cord. And then we also have other and unspecified injuries of cervical spinal cord. So based on the documentation, the coder would have to know where to look, okay? So these are the codes that I looked at: fracture of other specified cervical vertebra and other and unspecified injuries. So you would need to add these codes in addition to your G codes for the quadriplegia. So S12 fracture of the cervical vertebra and other parts of the neck. As you can see, you have to be really specific regarding these diagnosis codes. And when you go into your ICD-10 manual, you're going to find pages of descriptions of the types of cervical fractures that there are. Type 3, it can be displaced, non-displaced. You really need to know. And if it's unspecified, then it's unspecified. So here we know that we're talking about 4, 5, 6, and 7 for the cervical vertebra for the fractures. So these are the areas of the code that we would be using to tell you that it was fracture of those cervical vertebra. And then the other areas, you know, the character spaces would be filled in based on the type of fracture. And if it was, you know, an initial visit, which we know it's not, it's more of a sequela. So that is what would be coded. But let's move forward here. So, wait a minute, where am I? Sorry. So the next page, there is a note when you look up these S codes, and it says a fracture not indicated as displaced or non-displaced should be coded to displaced. That's in the guidelines in the front of the book. It's also in the body of the manual. A fracture not indicated as open or closed will be defaulted to closed, which means that the bone did not pierce the skin. And this includes fractures of the cervical neural arch, the cervical spine, the cervical spinous process, the cervical transverse process, cervical vertebral arch, and the fracture of the neck. But when you're going to code the fracture, which is the S code, underneath that, it tells you code first any associated cervical spinal cord injury that falls into category S14.0 through S14.1. So we know we have the G code. We know we are going to code the fracture because that's what caused, that was the reason for the quadriplegia. But it's telling you before you code the fracture, code the cervical spinal cord injury. So that means it will be the G code, the S14 code, then the fracture code. And in this case, we will have 7 character spaces. We need to indicate the encounter. And we have, for the fracture codes, you have A, B, D, G, K, and S, starting with the initial encounter for a closed, initial encounter for open, which are not applicable, subsequent encounters for routine or delayed healing, not applicable, subsequent encounter for fracture with non-union, not applicable, and then we have sequela. I mean, obviously, this patient was injured in 2015, so this is definitely an encounter, which is a sequela. Now, before, all right, so that's fine. We'll move on to the next. So when it's telling us to code the 614.0 to 614.1, the S14.0, S14.1, The S14 means injuries of nerves and spinal cord at the neck level. The S14.1 is other and unspecified injuries of the cervical spinal cord. And note, you want to code to the highest level of cervical cord injury, and you want to also code the fracture of the cervical vertebra, S12.0 to S12.6, not open wound of the neck and not transient paralysis. So when you first looked, we looked up the fracture, it said code first the S14, right? Now you're doing the S14 and it's telling you now to code also the fracture. So no matter how you look at it, it's telling you the sequence. And so you would do the G code, the S14, and then the S12 in that order. But for the S14, you only have 3 options for the 7th character. One is A, initial encounter, D, subsequent, and S, sequela. And that, again, would be in your ICD-10 manual, but you would be focusing on the sequela. And these are all the codes that you can choose in this area here, from the S14.101 through 109S. So it's A initial all the way to S, and those are all in your book. And that's, these are more of the unspecified injuries. And then you have the 1-1, which is the complete lesion of the cervical spinal cord, and the 1-2, which is the central cord syndrome, 1-3, anterior cord syndrome, and so forth. So you really, I know that you said the documentation was pretty poor, so hopefully you would be able to extract some information from that to figure out about the injury, but if not, you would have to focus on the S14.10, and then probably 9S. So the coding sequence, again, would be the G82.52, quadriplegia, C1 through C4 incomplete, the G82.54, quadriplegia, C5 through C7 incomplete, the S14.1 XXS, we'll say, other and unspecified injuries of cervical spinal cord, with the code also any associated fracture of cervical vertebra. And then you would code the fracture, the S12.XXX, and most likely the S for sequela, fracture of the cervical vertebra and other parts of the neck. Now, what I do want to stress here is, let me move here, that the guidelines are very specific for the coding. Now, if the patient encounter was, and the patient was being treated for breathing or heart issue or intestinal or any other health issue, and it's a result of the quadriplegia, well, that has to be coded first. You always ask yourself, why is the patient being seen? If it's just a checkup, because the patient has, you know, problems all the time with the ventilator, you know, just problems that may be associated with quadriplegia, then you would code in the sequence that I'm presenting to you here. But if the patient comes in because they're having extreme difficulty with their breathing or chest pains or anything, that's the reason they're being seen. That would be coded first. Then you would follow with the sequence. Okay, so just remember that when coding, the information that was presented to me by our club member, this is how I answered. However, if there is a very specific reason for the patient encounter, always code that first. Now, the other thing is, I'm focusing on this as being a standard, regular checkup, you know, because the patient has issues being a quadriplegic, and I'm using sequela. But if they come in for the first time and it has to do with a breathing or heart problem or anything, and you're dealing with these injuries, this is a first encounter for this type of a problem, then you're going to jump over to A, initial encounter, because it's a new problem. All right, so remember that it's all relative to the patient encounter. So, and I know it can even be confusing. Even I have to stop and think sometimes. But if it's just a basic, you know, exam, then it would all be sequela. But if they're coming in for a specific reason and it's the first time or whatever, then you just follow the guidelines for the initial, subsequent, and sequela. So thank you, Joanne. This was my question. This is from Stephanie Rees. The patient was being treated for wound care and the injury was a motor vehicle accident. Oh, okay. So there you go. You would have to code that first. you would code the open wound and everything related to that. And then you would indicate the complications due to being a quadriplegic or whatever, you know. So, and for the S codes, would you use all the codes to include the different levels of C4 through C7? It's a pain in the neck, but yes, you do have to use all those codes because they don't combine them. If you actually look, it'll say C1, C2, C3, and because it is 4, 5, 6, and 7, you would have to choose all those codes. So there's no combination there. So unfortunately for that. Now our next question, if there's no more here, is about mammograms or mammographies. And the two codes in question are G0206 and 77067. And there's a question about screening versus diagnostic. And it's interesting because this question was confusing to our club member because she was practicing with a program called Practicode. So I'm not really sure if there was a problem with Practicode in this particular question, or if the patient wrote it, the student or the club member misinterpreted it and wrote it in the question this way. But I'll address it so that you have a better understanding, okay? She goes, help, I am confused as to why the G code is more correct than the radiology code when the description for both is exactly the same, or is it just a Medicare thing with which I need to become more familiar? So when the question was presented for practicing, they gave whatever the question was, and the answers were G0206, diagnostic mammography, including CAD when performed unilateral, 77067, diagnostic mammography, including CAD when performed unilateral. They're exactly the same. So I agree with the student here, or the club member, that it is confusing, okay? And just so that you know, here is just a diagram of what the mammography looks like, which is the camera unit, the x-ray beam, the film plate, and the woman's breast that is squished down in here to be filmed. But there are definitely differences with the code. First of all, the G0206, there was a change in 2017. It used to have to do with digital viewing, and now it's not. So the wording had changed, and it is a diagnostic mammography, including computer-aided detection, CAD, when performed, and it is a unilateral code. And when you look this up, say, for example, in Find a Code, you look up the code, and it'll have like a Medicare physician fee, you know, schedule and all the indicators. And here it's saying Medicare coverage is carrier determined, and the service is paid under a fee schedule or payment schedule other than outpatient payment prospective system. It's an active code. There are no global days. It is PC, professional component, technical component indicators are required. There's diagnostic tests for radiology services. There are no payment adjustment rules with modifiers 51. And even though this is a bilateral surgery, 150%, 0 to 150% payment adjustment for bilateral procedures does not apply, which means that they will not pay 100% allowed for the first one and then 50% allowed for the second. They will actually pay equally. And it just goes on and it tells you what's allowed, what's not permitted. And underneath that, it says don't forget to use modifier 26 for the professional component only. That's the interpretation. Now, here we go. 77067. This is not a diagnostic mammography. It's a screening mammography. It's bilateral in the description. 2-view study of each breast, including CAD when performed. And there's very, very important information when you look this up. Medicare coverage, not covered by Medicare, not covered by Medicare, non-covered service. Why? Well, from the CMS website and findacode.com or so forth, For reasons related to claims processing systems in 2017, CMS will be unable to properly process claims using these CPT codes 77065, 77066, and 77067 for 2017. Therefore, for 2017, practitioners should report mammography services using G codes G0202, G0204, and G0206, depending on what procedure is being done. Now, from a testing standpoint, you shouldn't be asked anything that will focus on from CMS, okay, and all of this information. If you are taking them as a coding question, you just read the question and read the descriptions that are provided to you when you're doing your open book questions and answers. However, if this is a billing exam question and you're studying for your CPB, this information would be provided to you to allow you to code properly, because like I said, 15 questions in coding are on your billing exam. So, but for regular coding, you would just look up whatever is in your manuals, whatever information is provided in the guidelines, that's what you focus on for your answer. But if it was a billing exam question, you would go by what's in the book unless they provided you information, which they should, from CMS to help you pick the most appropriate code. So hopefully that will help you. So let's look at this and see the differences. G0206 is diagnostic mammography, including CAD when performed unilateral. That's the correct diagnosis. The one that was presented by our member, 77067, diagnostic mammography, including CAD when performed unilateral, is wrong. It's not diagnostic, and this code is not unilateral. The correct code is 77067, screening mammography, bilateral, 2-view study of the breast, including CAD when performed. So depending on what the question is, you would choose one of these. And if it was a billing test type of question and you had that additional information from CMS, you wouldn't even be looking at 77067 right now. You would only be focusing on the G codes. All right, so it all depends. And if you're billing and you ran into a problem where it got denied, that's when you would have to go on to the CMS website for your area, your MAC, your demographic area, and find out what the guidelines are for that. And just so that you can have a visual, the screening mammography or mammogram is 77067, and diagnostic. Here is a picture of a 45-year-old female, and she went in for a routine screening of a mammogram abnormality, I should say. And right here, you can see this nodule right in here in the breast. And that is what was found. So once the screening is done, then you would go on and build a diagnostic to get further information. I did coding and billing for an ultrasound group, and I did the coding and billing for breast scans. So after a screening mammogram where it came back that there was definitely problems, then they would go in for a breast scan. But that was this particular ultrasound lab. You could also go back in and do a diagnostic. So screening mammograms simply look for signs of cancer. These procedures are X-ray exams of the breast done yearly in women who have no breast symptoms or changes in the breast exam. So it's just a screening for breast cancer. And there are specific guidelines. Women ages 40 to 44 should have the choice to start annual breast cancer screening with mammograms, which are the X-rays of the breast, if they want to. Women 45 to 54, it's recommended that they get one every year. And women 55 and older should switch to mammograms every 2 years or continue yearly screening. And that right now is what the guidelines are. Sometimes, things change and they may actually change the time periods. But for now, this is what the guidelines are. So when something is abnormal or difficult to determine, a woman may be referred for a diagnostic mammogram, or okay, in this case, it's a diagnostic mammogram. So for example, if a woman with a breast problem, such as a lump in the breast pain, nipple discharge, or an abnormal area found on a routine screening, then you would get a diagnostic mammogram. Then if there's still an issue, you would probably go to the breast scan. Depends on, you know, how these tests are ordered. But the screening looks for trouble, and if there is trouble, then they go to diagnostic and research it further. And that's just showing how you see the series of pictures. So when they take the ultrasound or do the mammogram, that's the technical component where they're actually doing the filming of the breast. That's the TC technical component. The modifier 26 is the interpretation. And this is here, the radiologist looking at the pictures and making a determination. That is the professional component with modifier 26. If you build them together, if you do the professional and the technical, you would not even use modifier because it's global. But this is here, the film is taken, and this is showing the different films, and this is actually the radiologist looking at the film, which is the modifier 26, the professional component. Now talk about hospital admissions. This gets a little bit, because doctors, I'll admit, don't always give very precise type of documentation. So let's look here for some of the definitive diagnosis codes and how they would be coded. The question, it's pointing to coding hospital consults without any definitive diagnosis. Well, in most cases, and most payers, they really don't pay for consults anymore. It's usually the 99223, 22, or 21, which is an initial encounter with the patient in the hospital, and there is a modifier that's involved if you are the admitting physician. But there are some payers that still pay for consults, so we'll focus on that. But my provider has been on call, and the patients he sees do have cardio problems, but history of. So I'm left with coding diagnoses like shortness of breath, dyspnea, consistent with angina, and fever. Now I added and fever and for a reason, because I wanted to be more specific with the guidelines, but I can't use angina because it is not definitive, but I can use dyspnea. Since the provider is a cardiologist, I look for diagnosis pertaining to his field, but sometimes all the patient has is GERD, which is esophageal reflux disorder, and a lot of history of. So that's fine, except when he codes a 99223. Well, 99223, like I said, is an initial encounter in a hospital setting. So let's look and see what some of the guidelines are and how it pertains to this particular question. First of all, the patient is being admitted with signs and symptoms, shortness of breath, dyspnea, fever, and so forth. And he's saying it looks like it's angina, but he's not saying that it is. Uncertain diagnoses are those that at the time of discharge are still being documented as probable, suspected, likely, questionable, possible, still to be ruled out, or other similar terminology. At the time of discharge means that the condition the patient went in with in question upon admission must still be thought to be a diagnosis in question at discharge. But in this case, let's read a scenario and decide how we're going to code. Patient is admitted with symptoms of shortness of breath and dyspnea consistent with angina and fever. The patient also has a history of COPD and is started on IV steroids and IV antibiotics for possible pneumonia. The progress notes for the first couple of days document COPD exacerbation and probable pneumonia. On the last couple of days, the progress notes document COPD exacerbation and pneumonia. The patient is discharged after 4 days of treatment with a final diagnosis of COPD exacerbation and pneumonia. So this can go a couple of different ways. 99223, we use that initial evaluation, for the admission. You would use shortness of breath, dyspnea, which means labored breathing, fever, and personal history of COPD. You would be using those 4 diagnosis codes as your admission codes. Now, if that's all you're coding, because the doctor was called in and that was it, then those are the codes you would use, nothing more than that. Now, if this doctor was called in and then followed the patient, you would use the subsequent hospital visit. And I'm using 99233 simply as an example because I don't have all the information, but there are multiple options for subsequent hospital visits. So in this case, I would be using COPD exacerbation as a diagnosis, and probable and possible, because he's saying that, I would be using pneumonia, and I would use J18.9, which is an unspecified pneumonia. The patient also has a history of COPD and is started on the IV steroids and the antibiotics because it's possible he has pneumonia. And the progress notes continue to say that for the first couple of days and the last couple of days, it moved from possible to probable pneumonia. So I ended up using the COPD exacerbation as well as the unspecified pneumonia code. And then the discharge code, we have two options for that, 99238 and 99239. I chose the 99238 as an example. Use COPD exacerbation and pneumonia because the doctor wrote in his final documentation, final diagnosis by the physician was COPD and pneumonia. So we would only use the J18.9 because the physician did not clarify any type of infection associated with that pneumonia. So just telling you that depending on where you're at, you know, and again, at the time of discharge, if the diagnosis was still listed as probable or possible, indicating uncertainty, you would code that as if the patient already had pneumonia or it was an established pneumonia. So either way, it was in the documentation, but the doctor did indicate that the patient had pneumonia for the discharge. But if you're just focusing, as the question did, on the admitting diagnosis codes, this would be what you would be using. Why was he admitted? What was the reason for the visit, and so forth. So that being said, I would go that route. All right, so, oh my gosh, we're almost done. I thought I would be on this for a long time with a lot of questions, but obviously not. We have one more question, so we should be wrapping this up. And this has to do with physician assistant and surgeries. How do we code? So this is the question that was presented by our club member. I just broke it down a little bit so that you'd have a better, view of it. I am hoping to get some direction on billing for our physician assistant when she assists with surgeries. I am reading that we can attach modifier AS as long as we have documentation by our surgeon showing medical necessity and what the assistant had performed. I have also been told that the best way to handle the PA, or physician assistant, assist with surgeries is to bill for the surgeon only, but to create an internal tracking code in order to compensate the physician assistant for the work she performs. Would you mind sharing how you bill for your PAs assisting with surgeries? I appreciate any help you can give me. And I know it can be confusing because a lot of physician's assistants do bill as they are employees of the physician, and a lot of times we just bill under the physician and then indicate that the physician assistant worked on this particular case. In box 24J of your claim form, his individual MPI number would be there, but in this particular case the rules are a little bit different. All right, so what is a physician assistant? First, that he has to earn a bachelor's degree, which is 4 years, and it is a requirement for entering a physician assistant program. Then you gain experience working in healthcare, you attend a physician assistant program, earn a certification, apply for licensure, and complete an optional surgical residency. In addition to this, the physician assistant has to be credentialed and should apply for a national provider identifier number because he has a taxonomy code linked to his NPI, his national provider identifier number. So that being said, a taxonomy code, you can have a physician assistant who's simply a physician's assistant, but if he is a surgical physician assistant and it breaks it down even more, if it's general surgery or so forth, that taxonomy code basically tells the insurance company this is the type of PA that is working in the practice and is coding. So a physician assistant may perform surgical procedures requiring other forms of anesthesia only in the personal presence of the supervising physician. A PA may act as first or second assistant in surgery under the supervising of the supervising physician. All right, so that's one of the rules. Most plans recognize modifier AS appended to a service to indicate when assistant to surgery services are provided by a non-physician provider, such as a physician assistant, a nurse practitioner, or a clinical nurse specialist. This modifier is not to be used when a surgeon, a medical surgeon, a medical doctor, physician / surgeon assisting a surgery. These services would be billed with modifier 80, 81, or 82, depending on the situation, okay? Because we're talking about physician assistant, you're only going to use modifier AS. So the AS, it's used by physician assistants, nurse practitioners, clinical nurse specialist services for assistant at surgery. It's used to report non-physician practitioners or advanced practice practitioners who assist in surgery. This is very important. The PA provider, the physician assistant provider, reports his or her services using their own provider ID number with the appropriate site of service. Okay, so if it's in the hospital, that NPI number would be linked. Okay, now the provider is capable of taking over the surgery should the primary surgeon become incapacitated. And when you add the modifier AS, the reimbursement is only 10% of the provider's applicable fee schedule, which is the allowed amount for the primary surgery. So if a particular surgery reimburses the doctor, 100% of the allowed, and the allowed amount is $1,000, the doctor will get his, but the physician's assistant only gets 10% of that. So you want to remember, a physician assistant at surgery is required to actively assist the surgeon and participate in the actual performance of the procedure. The operative report documents the specific services the physician assistant surgery rendered. Modifier AS should not be used if the physician assistant is acting as an extra pair of hands and not a surgical assistant in place of another surgeon. So that's really important, and that will come into play depending on documentation. So obviously, if he's just that extra pair of hands helping the doctor, then just bill under the doctor. But if she's actually being an assistant at surgery, then you would attach modifier AS and bill under his NPI number. Modifier AS should not be billed with modifiers 80, 81, or 82. So that's basically what that's all about. So in summary, this really went fast because I didn't have any real questions, but in summary, focus on your guidelines, and more guidelines. Every single question that was presented today through the club, all my answers came from the guidelines. So there's an excellent opportunity to review these slides and go into your CPT and your ICDD manuals and just really see how I moved along and how the book guides you, step 1, step 2, step 3. Now, obviously, if you're a coder in the real world, you can go online to the websites and you can go in to find a code and so forth and get additional information to help you, especially if you're dealing with denials. But as far as just basic questions and answers for testing or for the exam, just follow the guidelines in the book to get your answer. You want to become familiar with them and use your BAT, the bubble highlighting annotation technique that's presented to you with CCO. I cannot recommend that enough. You really will learn a lot if you do that. Okay, and that is basically it. I can't believe this only an hour. I thought I would be an hour and a half. Does anyone have any other questions at all? I just
Looks pretty quiet here today.
Oh my gosh, I allowed extra time for questions, but maybe I was explanatory enough. I don't know, but anyway.
You did fine. You did fine.
All right. Well, maybe I'll add more questions next time just in case. So we'll see. But anyways, well, that's it then. I'm glad I was able to answer the C4 to C7 quadriplegic question and answer for Stephanie and Chantel. But that's it until next time, I guess. So everyone have a great afternoon, and thank you, Boyd.
You're welcome, and reminder to everybody that we have the Q&A webinar this Thursday, so go over to cco.us and you'll find the registration link there, probably right on the front of the page where to go. All right,
Wonderful.
So thank you everybody for being with us today, and until next time.
Thank you. Bye-bye.